Of this plenary session is Dr. Rohana Hatutua. He is the President of South Asian Federation of Obstetrics and Gynecology, Secretary General of Asia Oceanic Federation of Obstetrics and Gynecology. Dr. Rohana is an eloquent orator and a silver-tongued person to give the topic, Migration from the WHO Partograph to the WHO Labor Guide. Mr. President, I would request you to come up to the dais and take the floor. Thank you.
This one. Right. Thank you very much, Nusrat, for that very kind introduction. Good morning to everybody. I am very happy to see everyone very early in the morning. I am sorry to have troubled you to come early in the morning to listen to a lecture, but I am happy to see a great audience. And thank you. Madam, for chairing this session. It's a great honor to me to see you both chairing. Firstly, I would like to congratulate and thank Professor Firoza Begum, the President of the Society, and the Vice President, Professor Salma Rao, and the General Secretary, Professor Tabasam Praveen, actually, for inviting me and giving me this opportunity to participate. And also I congratulate everyone for starting this Fetal Medicine Association, Maternal and Fetal Medicine Society, which we don't have in our other South Asian countries. So this is a great thing which everyone can follow. And I am happy to see the activities which have been conducted by your society in the past. I also wish to thank Professor Firoza Begum, the President of the OGSP, the Professor Samina Chowdhury, who is the past President, and also our Professor Farhana Devan, who is in the chair. Actually, they have been very helpful to me, and especially Professor Farhana Devan. She is the Deputy Secretary General of SAFOG, and she is doing wonderful work in SAFOG. So, I will continue with my topic which is given to me today. It is migration from WHO Partograph to the WHO Labor Guide. So this is not a very advanced lecture, but it is somewhat basic, but it will help us to look after our patients, the mothers in the labor rooms well, and thereby have a wonderful delivery. So I have no conflicts of interest, but I have to acknowledge Professor Savaratnam Arukumaran for all his guidance. So this is my lecture. So I will be talking about why migrate from the partogram to the labor care guide, understand the historical aspects of labor curve and the recent research on labor progress curve and suggestions for the management with the labor care guide in the future, and I'll end up with some conclusions. So if you go back to the history, we all know in 1972 there were two landmark papers described, which describe the partograph. This chart to design, to provide definite referral criteria, referral criteria for midwives working in peripheral clinics who needs to refer women in labor to a major hospital in Harare Hospital, that is in Zimbabwe, which is then Rhodesia. So in the same period, the National Maternity Hospital in Dublin also reported on the active management of labor. And then after that, the partograph was globally adopted, and it has been used for more than half a century. And it is recommended by the WHO in the early 1990s, and it is a routine tool to monitor progress of labor. So if we go back, you will all know about this Friedman in 1954 introduced this the labor progress. This is the curve, the analysis of labor, and this is the alert line where you have the different the phases, the latent phase, the active phase, and so on. So there is a alert line which has been shown in that photograph, and all the normal laborers had to follow this the alert line. And Philpott and Castle then re-examined this in the African mothers and tried to implement it in African pregnancy. But unfortunately, they were not able to find the commencement of the labor. So when they were not able to find at what time the labor commenced, and also the rate of progress during the phase of maximum slope of 100 consecutive African primary carriers was half that of the American women. So they didn't progress at the same rate as in the what was shown in the graph of Friedman. So this alert line, as I said, it must separate effectively the majority of the normal patients from the abnormal patients, so that they can be transferred later safely to the central unit. And as I was mentioning, O'Driscoll from the Dublin Hospital came out with this active management of labor. So intervention was mandatory unless the cervical dilatation exceeded 1 centimeter each hour. Stimulation was by artificial rupture of membranes, followed by oxytocin infusion, so I think we all have heard about it, and also we would have been practicing this. In this photograph, if the left of the alert line, there was no action, but right of the alert line, then they had to be transferred to a from the peripheral unit to a central unit. And then once it crosses, then there is another action line, which is 4 hours right to the alert line. And if it crosses that, then action had to be taken. So there was a WHO model photograph was derived by the information from a working group. This working group considered the Professor Arul Kumaran worked in Indonesia, Thailand, Ken Stewart, in Malaysia, Chris Lennox, and so with all these group of workers, they came out with this WHO photograph, which said the active phase of labor commenced at 3 centimeters of cervical dilatation. So the latent phase of labor should not exceed 8 hours. And during the active phase of labor, the labor should progress at 1 dilate 1 centimeter per hour, and should not be slower than that. And so these were the recommendations by the WHO then. So you can see here, there is an alert line, and then 4 hours to the right, you have the action light. Even if it crosses the alert line. It is within the action line. You don't have to take any action, but can be referred to a central unit if necessary, and only action is taken if it crosses the active action line. But even though this partograph was used, we can see the cesarean section rates from 1990 to 2014 has been gradually rising throughout the world. So in spite of this partograph, so you can see in this map also the change in trends in the cesarean section globally. So still there was a high rate of cesarean sections in spite of all this. So what was observed is the quality and outcomes of childbirth care remains suboptimal in many health facilities in low resource settings. And most of the complications during childbirth, during labor and childbirth could be averted with timely interventions. And to accelerate the reduction of childbirth-related material, fetal and newborn mortality and morbidity, the World Health Organization initiated what is called the Better Outcome in Labor Difficulty, the BOLD project. So this is to address the weaknesses in labor care. So, so in this article, you can see what I was mentioning earlier, that for over 40 years, the partograph has been the central tool for risk identification and interventions. So despite the wide acceptance, the use of partograph has not successfully improved the birth outcomes. So there were several notable factors like incorrect or inconsistent use of the partograph, and also the time constraints. The workforce was not enough to implement it, and there was a shortage of skilled workforce and lack of knowledge of the partograph. So all these also contributed for it not being used universally everywhere. So the simultaneous monitoring of women in labor and delivery and timely and appropriate action, in particularly the challenging for health workers in labor units. So, and there is no clear evidence that the use of the partograph has had a positive impact or in important clinical outcomes. So there is also increasing evidence that the pattern of spontaneous labor progression may differ considerably from Friedman's reports, that is 1 centimeter per hour. So what was the action taken? So this embarked on this BOLD project. It will address the critical barriers to the process of good quality intrapartum care and enhance the relationship between the health systems and the communities. So what was the proposal? Is developing an evidence-based, easy-to-use labor algorithm. So it is a labor monitoring to action tool. It not only monitors, but there is action section also. So it has to be a simplified, effective, and labor monitoring to action tool. So that is called CELMA. And also then they developed a passport to safe birth that is using the designed with communities and healthcare providers to promote access to quality care of women during childbirth. So this is the WHO BOLD project. So on a sideline of this BOLD project, as a part of the WHO BOLD project, they examined the patterns of labor progression in a prospective cohort of women in Nigeria and Uganda who gave birth vaginally without adverse birth outcome following spontaneous labor onset. So they collected data of 5,606 women and they gave birth vaginally in 13 maternity hospitals in Nigeria and Uganda. And the findings showed in this big study the application of population average labor curves that we were using could potentially misclassify women who are slowly but normally progressing as abnormal. So sometimes with the photograph which we are using, we would have been categorizing some women who were normally progressing, but they were progressing slowly, and they were categorized as abnormal, and we would have been taking unnecessary action. So you can see the distribution of the cervical dilatation in these 5,600 women. So it didn't follow this straight line or the sigmoid curve of Friedman. But all these ended up with normal vaginal deliveries. So that shows that what we have been using, we have to think further. So here, if you take the alert line and the action line also, so that also you can see there is diversity in the progress in labor. So even sometimes we cross the action line, but still the labor progressed normally and gave birth to a normal baby and without any complications. So all this gives us and tells us that we have to reconsider. So the conclusion, so in the slowest yet normal women can progress more slowly than the widely accepted benchmark of 1 centimeter per hour, irrespective of the parity. So this 1 centimeter per hour is not a standard. The cervical dilatation rate of 1 centimeter per hour throughout the period traditionally described as active phase may be unrealistically fast for some women and should therefore not be universally applied as the threshold for identify abnormally progressing labor. So most nulliparous and multiparous women, labor may not accelerate until the threshold is at least 5 centimeters. So the acceleration starts only after 5 centimeters. So intervention to expedite labor to conform to cervical dilatation of threshold of 1 centimeter per hour may be inappropriate, especially when it is before 5 centimeter dilation. So average labor curves may not be truly reflect the variability associated with labor progression, and their use in decision making of labor management should be disregarded. So then here is also another study done by Shang and others. They studied 1,325 nulliparous women, and also you can see how it deviates from Friedman's curve. And from here you can see that cervical dilatation from 3 to 4 centimeters, median is 1.8 hours, 4 to 5 centimeters, 1.3. It is only after 5 centimeters it becomes less than 1 centimeter. So actually you can understand that the active phase starts only after 5 centimeters. So it is not at 3 centimeters. So you can see, so the active phase of labor may not start until 5 centimeters of cervical dilation. And a 2-hour threshold for diagnosing labor arrest may be too short before 5 centimeters dilatation. So, we can't say that the labor is not progressing well if it exceeds 2 hours. And a 4-hour limit may be too long after 5 centimeters. In the 5 centimeter, after 5 centimeters, the labor progress is very rapid, less than 1 centimeter. So waiting for 4 hours to take action may be too long. So given that cervical dilatation accelerate as labor advance, a graduated approach based on levels of cervical dilatation to diagnose labor protraction and arrest is proposed. So as you see, as the labor progresses, the cervical dilatation rate also increase. So there must be a graduated approach. So the American College of ONG in a consensus statement has stated the cervical dilatation of 5 centimeters should be considered threshold for active phase of most women in labor. Thus, before 6 centimeters of dilatation is achieved, standards of active phase progress should not be applied. So even the American College guidelines approves that. So in this whole project, there were other things which were considered. What matters to women during childbirth? It is not only looking after the labor and this thing, but the mothers want much more than just monitoring labor from those who are attending to the labor. So this includes giving birth as a healthy baby in a clinically and psychologically safe environment with continuity of practice and emotional support from a birth companionship and kind, sensitive clinical staff who provide reassurance and technical competency. So there are so many other things which will help the labor to progress well and to have a happy ending. So this whole project, what they came up with is firstly respectful care. So women express the need for supportive and respectful care during labor. And then good communication. Women wanted providers to take time to communicate slowly and clearly to them so that they are empowered to make a decision. So they have to be kept informed throughout labor about their progress so that they have confidence and they are able to progress in labor, because otherwise what they will be doing is they will want to terminate the labor and have a cesarean section. So it is always important that there is a health worker who is communicating with them very well. And if there is a labor companion, most women would prefer to have their husband or a female relative with them because they felt lonely and scared. So that is also encouragement for them to proceed with the labor. So because nowadays, so many primigravidas are very scared and they ask for an elective cesarean section from us. So these are some of the things which we can attend to that will make them decide to go for a normal labor. So these are things which we have sometimes not be concentrating very much. And so there must be essential physical resources in the hospital. Women thought that hospitals were dirty, especially the patient toilets. So women described the waiting area of the hospital as overcrowded and overflowing, and so many things which the patients encounter some difficulties which they come across. So we have to make the environment friendly for the patient. So these are things which we sometimes don't think about very much, because we are mainly concerned with the patient's medical aspect. And then actionable information system. Providers expressed frustration when medical records were not completed in a timely fashion. Photographs are often completed after the delivery rather than used as a tool to assess the progress. So these are things we have to accept that in some of our hospitals which are taking place. So we are doing all these things is for the well-being of the mother and the baby. So because of with considering all these research findings and the recommendations, the WHO made the WHO design this labor monitoring tool called the WHO Labor Guide. So this is the WHO Labor Guide. You will be able to download it from the internet. So it gives all the information of how to use this WHO Labor Guide. So here it is about this WHO next generation partograph, the revolutionary steps towards the individualized labor. So here it says that the labor care guide includes assessment of labor companionship, oral hydration, maternal position and mobility, and pain management. So some of these things were not included in our earlier partograph. So this is the WHO Labor Care Guide. So I'll show you there is the alert parameters. So that is something which we have to take note very much, and under each observation. So here you can see in the labor, in the labor guide, the first section is about the introduction and about the details about the patient's details, and then you have the time from that is the time they entered. We started this labor care guideline, and each box is 1 hour. And then the other one is in hours, that is how many hours, 1 hour, 2 hours, 3 hours, like that. So you can see on the side, there is an alert section. And so if you go down that column, you can see in the alert, under the companion, you have to write yes or no. Here it says N, that means the companion is not there. Then pain relief, whether it is given or not, no. Then oral hydration, whether it is given or not. Then regarding the position of the mother, so whether the mother is mobile, upright, or supine, or whatever. So these are things which are being noted. And here in the next section, the section 3 is about the care of the baby, so which we have been always recording. That is baby's heart rate, and then of course here we have a section for decelerations, where you listen to the fetal heart rate just during the contraction and after the contraction, and you can see whether there are decelerations. So the fetal heart rate, the limits are between 110 to 160. So that is the alert. And then also about the baby, about the amniotic fluid, whether the meconium clear also, and the fetal position, posterior, occipital transverse, those are the ones which we have to keep an alert. Then caput, if it is 3 pluses, then it is an alert thing. So the molding also like that. So then in the mother, you note down the pulse, blood pressure. Pulse, it should be within 60 and 120. There is a guideline. So if you see the alert line, if someone crosses this line, then we have to take further planning and action. So this is the progress of labor. Here you have contractions, how many per minute within the 10 minutes, between 2 and 5. And duration of the contractions, whether it is less than 20 seconds or over 60 seconds, then that is something we have to take action. Then also you can see the next section. So that is the most important thing. It is cervical dilatation. You can see we start from 5 centimeters. There is no from 1 to 5 centimeter dilatation. The initial photograph had from 1 centimeter, not centimeter, 1 centimeter. So, but we will go into that later. And also you can see there is different time intervals given for various dilatations. And then of course you have the descent of the head. So then this one is regarding the medication, and then after that you have the assessment, and if there was something which we have to take alert, we have to mention that, and then we have to discuss with the others in the team and write down the plan. So this is not only assessing but also planning and necessary action to be taken. So that is how this is not only just noting down the findings. So we have to assess and then plan and take the necessary action. So at the very bottom you can see the after delivery, about the mode of birth, blood loss, and so on. So the labor care guide has the comprehensive recordings of the maternal vital signs, fetal well-being, and labor progression. And it has, as I mentioned, reference values for maternal and fetal observations. And in the assignment segment, the caregiver records the overall assessment and any additional findings not previously documented but important for labor monitoring. In the plan section, the care plan formulated after discussion is documented. So this establishes the labor care guide as a contemporaneous monitoring and response tool. So this is just to show how it has been marked. So you can see the companion has not been there early, then later the companion has come in, so then it has become yes. So the pain relief, firstly there was no, then in the next hour we can see it is yes. So the oral fluids also like that, and the posture that is mobile earlier then has been supine, but supine position is not correct, so that is why it has been highlighted. So supine position is, so like that all the other sections also being monitored. So they are monitored 1 hourly, but the cervical dilatation 4 hourly. So in this section, how the blood pressure and the others have been, then fetal position, if it is posterior, we have to take note of it. And if it is transverse, it is also, we have to take note of it. So like that. So the duration, so in this labor care guide, regarding the latent phase, what do we know? Duration and onset of the latent phase is difficult to define. And premature plotting of suspected latent phase and the duration fixed for 8 hours in the original past photograph resulted in unnecessary intervention. So this is avoided in the labor care guide by only initiating documentation of labor progress once the active phase has been diagnosed. So that is something very significant. So otherwise we unnecessarily say that the patient is not progressing and do unnecessary things, and they end up with unnecessary surgical. So, and then the division of the active phase. The original partograph was defined it as 3 centimeters, but now here the labor care guide uses 5 centimeters. No adverse perinatal outcomes was found in the low risk women, even if the dilatation rate was less than 1 centimeter per hour. So even in the active phase, this reduces premature designation of the active phase of labor. So the second stage of labor. So in the original partograph, there was no requirement to continue monitoring during the second stage of labor. But we know there is increased uterine activity and more expulsive efforts from the mother in the second stage of labor, particularly during this critical time. So this, if there is reduced vigilance at this time, this may result in poor outcomes. So in the labor care guide, there is a closer monitoring in the second stage. So, so this compares the differences between the partograph which we are using and then the present WHO labor guide. I mean, all these things I would have been describing. So, in conclusion, what I have to say is that this guide, labor care guide, is a guide to monitor, its monitoring and documentation of the well-being of women and babies and the progress of labor. And the guide is for skilled health personnel to offer support care throughout labor to ensure a positive childbirth experience from women, and to assist the skilled health personnel for promptly identify and address emergency labor complications, and so also to prevent unnecessary use of interventions in labor, and it also support audit and quality improvement of labor. So as you can see from what we were discussing, that there were certain deficiencies in the partograph which we were using, and the research which followed showed this, and so the WHO has taken steps to rectify this and to attend to these problems, and they have come up with this labor care guide which may be helpful and which will help us to monitor the labor properly and for us to take the proper action without unnecessarily intervening. So finally, I would like to conclude by welcoming you to our Suffolk conference, the Silver Jubilee Suffolk conference, which will be, so this is a great opportunity to all of you to visit Sri Lanka, and so that will give us another opportunity to meet each other in person. And so this will be a wonderful congress. And I must just also mention that Professor D.H. Chowdhury will be honored by a fellowship of the Sri Lanka College of Obstetrics and Gynecologists. So I am sure that you will be in large numbers to cheer him up at the opening ceremony. So the registration is now open, so you can go to the website and register. And there is discounts for group registration. So please, so these are some of the plenary lectures and the orations which will be there. And you go to the website, all this information will be there. So thank you very much for your patient hearing.
Thank you, Mr. President, for your beautiful presentation. It's really in-depth and time-demanding. May I now request our, please have a seat. May I now request our distinguished chair to make comment? Professor Anwara Begum, Madam, please.
Thank you. Good morning to everybody. First, I want to thank Dr. Rohana Malhotra about his brilliant lecture on migration from World Health Partogram to World Health Labor Guide. He has very nicely described, started from the history and different graphic records and different studies to show what is the partograph and what are the pitfalls of partographs. Now, when we started the partographs, the main aim was to prevent the prolonged labor and to refer the patient from primary care centers to secondary or tertiary care centers. Then what happened? We started it also in the institution and found that cesarean section rate of unnecessary action has increased after using the partograph. So came World Health Organization Labor Care Guideline. And in this labor care guideline, the most important thing is the active stage of labor started from 5 centimeters instead of 3 centimeters in previous partograph. And this care guideline also includes some different things like the respectful maternity care, like the maternal companionship, their behavior, and what are his position, how is she like this. And also it includes the second stage of labor, because in original partograph there is nothing mentioned about the second stage of labor, and in second stage of labor we had so many problems in second stage of labor also, and that is also included in this guideline. I think it was a wonderful lecture from Rohana, and I again want to thank Rohana, and we have learned a lot from you, and I think we are also trying to start the World Health Organization Labor Care Guideline in our institutions. Thank you. And I think it is my privilege to hand over the microphone to Professor Farhana Dan, who is the chairperson and who is in fact working on labor care guideline in Bangladesh. Thank you.
Thank you, Professor. At the outset, I would like to thank Professor Firoza Begum for giving me the opportunity to chair this very important session in this esteemed platform. Regarding Dr. Rohana, many of you have heard, he is the sitting President SAFOG, he is the Secretary General of AFOG, and he is a very, very hard-working person, and he is doing a lot for contributing a lot for SAFOG. So I think when he was president-elect and Professor Ferdowsi Begum was the president, he also worked a lot, and I am fortunate enough to work in SAFOG as the Deputy Secretary General with Professor Rohana. Can we give a big hand for Professor Rohana? Thank you very much. Now coming to the topic, as you all know, we have been working with the partograph for a long, long time. From 2000, the first partograph came up, and then 2001, from 1990, the first partograph came, and from 2001, we started the WHO modified partograph where the latent phase was removed. But you know, in the labor care guide, they're talking about taking care of the woman in the latent phase, not doing it in the labor care guide, but taking care of the woman, as also in the second phase, because the woman is there and we have to look after her. So we have been working with the partograph for a long time. We have seen what is the problem. Like some of us are plotting it later on. That was one big problem. And then the woman was taken quickly to cesarean. And you know that I always feel that why? The multiple pregnancy, how do we plot the twins? Then primary and multi, how do we do it? Because the behavior of the labor is very much different in primary and multi, but we didn't have separate ones for that. So then WHO found out this problem, what Dr. Rohana has already mentioned, that there is the difficulty of the people plotting it, interpreting it, and of course, we all know about the alert when the active phase starts. After study for a long time, Zhang, he found out, well, people have been using partograph for a long time, but they didn't realize that the active phase, women didn't go into active phase unless the cervix is 5 centimeter dilated. So that was another thing. We had to change the partograph. WHO partograph and come to a new one. So in this, we have seen another thing, you know, in the labor care guides, so it has come. So during the transition, when WHO did a study, they found that they did the BOLD project, that is the better outcome from labor and delivery, labor difficulties. It found that what is the problem with the labor? Well, we can now solve these problems. And what do women want? What are their experience? They want a positive childbirth experience. They want a better, respectful maternity care. They want a companion. They want taken care of them. And that was all included in the BOLD project. And the BOLD project, and from the BOLD project, they said, well, we will develop a new tool which will be a transition from the WHO one, where the women will be taken more care of and the labor outcome